Hadcroft. I'm a respiratory consultant in Liverpool. I work in the Royal Hospital, and I work with the Liverpool Community Respiratory Team. So this is a talk that I've given to the Community Respiratory Team recently about community-acquired pneumonia and sepsis. So the Liverpool Community Respiratory Team currently just manages COPD exacerbations, but we will be moving into pneumonia and other areas as part of the respiratory virtual ward. So what I'm going to talk about is clinical presentation. So how to recognise pneumonia. So how do patients with pneumonia present? Very similar really to how patients with exacerbations of COPD present. I'll talk about severity scoring, which is really important because severity scoring not only predicts mortality, but also will determine which antibiotics are most appropriate to have. I'll talk about organisms that cause pneumonia, and we know nationally what the most likely organisms are for pneumonia. We know locally what our commonest organisms are, and we know locally what our sensitivities are. So again, knowing the organisms predicts which antibiotics are most likely to be successful and helps us treat patients with pneumonia without needing to know there and then the organisms or what's in the sputum, and then treatment, antibiotics, and where and what route of antibiotics. So pneumonia is essentially it's kind of a contraction of pneumonitis, and itis is inflammation and pneumo pertains to the lung. So essentially pneumonia is any cause of pneumonitis, and it can be drug induced, it can be chemical, it can be bacterial, viral, fungal. When we talk about pneumonia, we're usually just talking about organism inflammation of the lungs. So it's usually bacterial, viral, fungal, rather than the non-infective causes of inflammation of the lung. So when we talk about pneumonia, we're talking about infections that affect the lung parenchyma. And you can split it up into different categories. So we talk about community acquired pneumonia versus hospital acquired pneumonia. Why does it matter? Because the organisms are different depending on where you pick up your pneumonia. So again, your antibiotic choice will be governed by whether we think the pneumonia is community acquired or hospital acquired, because we need to pick antibiotics that will treat the likely organisms. We can talk about sporadic versus epidemic. So sporadic is essentially the pneumonia that we tend to see every so often in a patient, as opposed to a massive outbreak. We've all lived through an epidemic pneumonia, haven't we? Three years ago, caused by virus, by which I mean COVID, in case you needed me to spell that out. So that was an epidemic. In fact, it was global, so it's pandemic, wasn't it? And other epidemics of pneumonia are often flu pneumonia or Legionella. So Legionella is kind of your classical epidemic pneumonia caused by chlamydia. Legionella pneumophila. When we're thinking about pneumonia, the commonest organism, commonest family of organism is probably bacteria. Maybe between about 2/3 and 4/5 of pneumonia are caused by bacteria, maybe 10 or 20% caused by atypical agents, and then viruses 10 to 15, although I suppose 2 and 3 years ago that percentage will have been higher, and the other percentages will have fallen to accommodate the COVID pneumonia that we're all seeing. So when we're looking at organisms that cause pneumonia, that cause sporadic pneumonia, we often see Streptococcus pneumoniae, so the pneumococcal pneumonia. So that's the commonest organism causing pneumonia. So we want to make sure that the antibiotics that we prescribe for somebody with pneumonia will cover Streptococcus pneumonia, because that's the most common. We've got Chlamydia pneumoniae, we've got Mycoplasma, Haemophilus influenza that we see quite a lot in COPD actually. So it's less common as a cause of pneumonia, but still important one to recognise and be able to treat. Legionella I've mentioned kind of briefly already. Then we've got Chlamydia psittaci, which is a bacterial infection you can catch from sick birds. Moraxella is less likely than most of the others. Staph aureus is uncommon, but more so after somebody's had influenza. So if somebody's had influenza and then develops a pneumonia, bacterial pneumonia, it's highly likely that that's a staphylococcal pneumonia. So if we were looking at treating a pneumonia that was after flu, we might pick an antibiotic that would cover Staph aureus over other alternative antibiotics. Sometimes we get gram negatives, viruses we've talked about, and again 13%, but that was pre-COVID. I don't think there's a lot of viral pneumonia around at the moment, but there certainly was 2 and 3 years ago. And in a third of cases, we never actually identify an organism, regardless of what we send off. We could send off sputum, we could send off blood, we could send off urine. But in a third or so of cases, we never identify an organism, and we're using our best guess. So most pneumonias are caused by bugs that we just carry around in our noses, and we aspirate them day in, day out, and our lungs deal with them, and they don't take over and cause disease. But occasionally the conditions will be right for the bugs to take hold. So whether it's changes in your lung or changes in your immunity. So sometimes our own organisms, our own nasopharyngeal organisms will cause pneumonia. Often inhalation of droplets from infected humans. So people with pneumonia that cough and sneeze, we can inhale the aerosol, or we can inhale the droplets, or droplets will be deposited on hard surfaces, door handles, bus bell presses, or bus what do I mean? The uprights. What the hell are they called? Bus rails that you hold on to when you're on the bus. So that's why it's really important to wash your hands regularly, to try and reduce the amount of organisms you've got on your hands that you might put up your nose or rub all over your face. Can catch them from animals. So there are pneumonias you can catch from infected animals, in particular birds, so the Chlamydia psittaci I mentioned already, and then environmental organisms, so stuff that lives in the soil, around and about, things like atypical mycobacteria. People can become infected with that. So in terms of clinical presentation, what symptoms do people have? They will often be breathless because they've got consolidation in a lobe of a lung, and that essentially interferes with gas transfer and drops oxygenation. Patients will often have a cough, usually productive. Green phlegm could point to pneumonia, but it can be dry, particularly in unusual organisms like chlamydia, Legionella. Sometimes patients will cough up blood, and it's usually not frank blood. It's usually blood mixed with sputum. So if a patient has a history of coughing up blood, I think it's always worth asking, is it just blood by itself, or is it blood mixed with phlegm? And if it's blood mixed with phlegm, what colour's the background phlegm? So often green phlegm with blood in could be bronchiectasis or could be pneumonia. I'd be less worried about that than frank hemoptysis, which is pure blood, so blood not mixed with anything else, and that might suggest something like, I don't know, a PE or a lung cancer. You can get frank hemoptysis with a pneumonia, but it's less likely than less common than blood mixed in with green phlegm. Chest pain, usually pleuritic, and the reason that people get pleuritic chest pain is pneumonia is inflammation of the lung. If the inflammation extends out to the lung edge and involves the pleura, then you get inflammation of the pleura, and the pleural surfaces will rub against each other as the patient breathes in and breathes out, and makes this pleuritic chest pain. So this sharp stabbing pain on inspiration, sometimes accompanied by a pleural rub. So that's kind of pleuritic chest pain. So that's pleurisy, inflammation of the pleura, which can be a consequence of pneumonia. Obviously, pleuritic chest pain and frank hemoptysis might send you down an alternative path. People sometimes get dull pain, especially if they've got bronchiectasis and they get pneumonia or an infective exacerbation, and they get a dull pain over the area of inflammation, the area of infection, but more often it's pleuritic. And then your constitutional symptoms that you can get with any infection, so fever, malaise, sweating, muscle aches, joint aches, being off your food and having a headache. Patients can also present with abdominal pain, and I can remember 3 or 4 patients in my career where they've presented with an acute abdomen, and the surgeons have done a CT abdomen, not done a chest X-ray, done a CT abdomen, and that's picked up pneumonia at the lung bases in a normal abdomen. So sometimes you don't get respiratory symptoms, you just get abdominal pain, and that's because you can get referred pain from a pneumonia to the abdomen or the shoulder or the back. Confusion is a worrying symptom because it can be a marker of severe pneumonia. It can suggest severe infection. It can suggest hypoxia. Sometimes it might point to Legionella or chlamydia. So if somebody's confused, you'd worry a bit more about those two, or the fact that somebody might have a very severe pneumonia. It's worth asking about travel. If people have been to places where weird and wonderful organisms live, then they might have picked them up and brought them back with them. And there's also places where there's penicillin resistance to some pneumococcus, in particular in Spain, where I think people can buy antibiotics over the counter, so they've got a lot of problems with antibiotic resistance. So travel's important to try and work out which organism might be causing the pneumonia, and also to help you decide whether you need to think about different antibiotics if there's the potential of there being a penicillin resistant organism in play. Pets, useful to ask about, particularly birds. And if people have got birds, it's worth asking if the bird is well or sick. And if the bird is sick, the bird might have passed on their chlamydia psittaci to the human, and the human might have chlamydia psittaci pneumonia. Worth asking about contacts, anybody else around and about unwell. And I think in our COPD day work, we've all seen patients whose grandchildren come and see them with snotty noses, and they pass on their bugs, and then their grandparents develop an exacerbation of COPD. And similar things can happen if contacts have got pneumonia. It's also worth asking about risk factors. So anything that would make patients at risk of getting pneumonia, usually immunosuppression. So are they on chemotherapy? Have they got active cancer? Are they on other immunosuppression, which is quite common now for a lot of conditions? Do they have diabetes? Do they have issues with alcohol excess? So all of these things can act as risk factors for pneumonia, and can immunosuppression is a particular issue. And the more immunosuppressed you are, the more likely you are to develop a more severe pneumonia. So once we've taken the history, we do a clinical assessment, and we measure temperature because patients might be running a very high fever. It's not just high temperatures that are of concern. Low temperatures can suggest a very severe infection, very severe pneumonia. So be worried about temperatures of less than 35. Heart rate, and again, patients can be quite tachycardic if they're heavily infected, or if they're hypoxic. And also slow heart rates can be concerning as well, because that might suggest more severe infection. Respiratory rate will often increase in pneumonia as a response to infection, but also a response to hypoxia that pneumonia can cause. And then when we're examining the chest, we always talk about inspection, palpation, percussion, and auscultation. So when we're doing our auscultation, we always feel for tactile vocal fremitus, and we're feeling one area of the lung, or one area of one lung, and we compare it with the same place on the other lung, and we're feeling for any difference in vibration there. And in pneumonia, you would expect to pick up increased tactile vocal fremitus, so an increased vibration over the area that's involved, the area of consolidation. And that's because you get a lot of inflammatory cells, and the lungs becomes quite solid. Solid molecules transmit vibrations, better than air or liquid does. So you actually feel that as an increased vibration. And vocal resonance is essentially the same sign, but down the stethoscope. So if you checked 99s when you were listening to a patient, you should hear an increased volume over an area of consolidation. Percussion note is dull, but not stony dull over an area of consolidation because of the solid element. If the area is stony dull, you might think about an associated effusion, which can occur with pneumonia, or even an infected effusion, which would be an empyema. And then we listen to breath sounds, and breath sounds are normally called vesicular breath sounds, but if they're abnormal, we call it bronchial breathing. So these sound much harsher, and instead of a nice kind of gradual inspiration and expiration with no gap in between, you get a harsh inspiration and a gap, and then a harsh expiration. We call that bronchial breathing. Added sounds in pneumonia are usually coarse crackles because you get inflammatory exudate in the alveoli, and as you breathe in and out, the air bubbles through the inflammatory liquid and causes a bubbling noise, which is a wet crackle or a coarse crackle. And as mentioned earlier, you can get pleural rub if the pleural surfaces are involved, so listen out for those things. Confusion is a worrying sign, as is hypotension. Cold sores can go with pneumococcal disease. So if somebody's got a cold sore, it's more likely that their organism is pneumococcus or strep pneumoniae than any other organism. And then we do investigation. So this is in the hospital. Perhaps in the community if we've got point of care testing, but often in the community, patients are managed without any investigations. But in the hospital, certainly, we'd be doing a full blood count, essentially looking for a white cell count. We'd look for a high white cell count, which is a marker of infection. The higher the white cell count, the more severe the infection. And again, if your white cell count is suppressed, so if your white cells are less than 4, then that can suggest either a severe infection or immunocompromise leading to infection. UNEs are an integral part of assessing patients' pneumonia severity. You can get an acute kidney injury with pneumonia, and urea is one of the areas that's scored in Curve 65 scoring that determines severity of pneumonia. CRP can be useful if it tells you what you want it to do. It's an inflammatory marker. It will go up in infection and other inflammatory conditions and come down as the infection improves, but it does lag behind clinical deterioration and recovery by a little while. I think it's in some of the guidelines. I don't think it's particularly helpful in terms of diagnosis or monitoring people, because as long as they're clinically improving, I don't think the CRP adds anything. Although if somebody's not improving and CRP is climbing, I might worry about development of an empyema. Strictly speaking, you can't diagnose a pneumonia without a chest x-ray. So pneumonia is inflammation of the lung that we should see on a chest x-ray. In the community, we don't, at the moment, usually send people for pneumonia, although I think we don't usually send people for chest x-rays, although I think for respiratory virtual wards, we probably ought to, but GPs will often manage patients and diagnose a pneumonia without checking a chest x-ray. And the other side to that is sometimes the inflammation is subtle enough that we don't see it on a chest x-ray. So sometimes if people have got in hospital and they have a CT for another reason, so we don't usually use CT to diagnose pneumonia. But sometimes if they have a CT for another reason, the chest x-ray can look clear, but there can actually be inflammation that we can see on the CT. So I think essentially chest x-ray is quite a blunt tool in diagnosing pneumonia, but if there's consolidation there, then you can be sure that there is a pneumonia. Sputum culture is really useful, not necessarily immediately because it takes 48, 72 hours for a result to come back. But I like to send sputum cultures mostly because if the patient's not getting better at 48, 72 hours and you're thinking of changing antibiotics, it's really helpful to know what organisms you're dealing with and which antibiotics you should step to, because otherwise you go from blind treatment to another blind treatment. So I'm a great fan of sputum culture. Blood culture is very useful in severe pneumonias, and sometimes can be positive with a negative sputum culture. So again, that can add information to treatment, especially if you need to alter antibiotics if people aren't getting better. You can send blood and urine for serology. We don't deal with blood serology very well because this needs paired samples a couple of weeks apart. So we're very good at sending the initial one, but very rarely does anybody send the convalescent one, and you can't really interpret a one-off blood serology. Urine serology, however, is very useful. I think we diagnose quite a lot of pneumococcal infections on pneumococcal antigen levels in the urine, and that should be part and parcel of any moderate to severe pneumonia management. And when you're talking about a severe pneumonia, then urine can be sent for Legionella as well, and that's a good way of diagnosing it. Oxygen saturation's not really an investigation as such, but part of the assessment. But again, it's important to know if somebody's hypoxic because they will need supplemental oxygen, and also blood gases to see how hypoxic a patient is, if they're hypoxic on their saturations. And for our patients with COPD, especially those that CO2 retain, it's handy to know what their CO2 and pH are doing. So this is a chest x-ray, and I will assume little knowledge of chest x-ray, but I know that many of you out there will be able to interpret a chest x-ray. But just so that this works for everybody, I'll talk you through it in a very simplistic fashion. So here is the right lung, here is the left lung. The lungs are filled with air, so on a chest x-ray they look black. Anything that's solid or liquid will look white. So here we've got the clavicles, we've got the ribs here, the stripy bits there, we've got the heart here, and we've got the scapulae there, the humerus, and the vertebral column. And if you believe in God, you could say that God gave us two lungs on purpose so that we can compare one with the other. And there's quite an obvious difference between the left lung and the right lung here. So this is black all the way down, and this here is black at the top 2/3 and white at the bottom 2/3. And this whiteness here is consolidation. So this is a right basal pneumonia. You can see the left heart border, so it's probably not a lower lobe pneumonia, it's probably a middle lobe pneumonia because you can't see the right heart border there. But this is consolidation at the right base, and you can definitely see difference between the black air at the top of the right lung and the white area of consolidation at the bottom of the right lung there. So that's a right-sided pneumonia. This one here is a bit more subtle, but again, if we compare the left lung with the right lung, we can see this kind of hazy whiteness here with a nice straight line there. So this is the right horizontal fissure, and everything below there is lower and middle lobe, and everything above here is upper lobe. So this is a right upper lobe consolidation. So that's a right upper lobe pneumonia. I put this one in because again, this is right lower lobe opacification, so whiteness. But can you remember 2 x-rays back? You could still see the ribs behind or through the area of whiteness. This here is really quite dense and obliterates the ribs. You can't see them very well at all. And if you just look here, you can see this kind of round edge to it, and this is what we call a meniscus. So this is what happens if you get liquid. So this is either a pleural effusion or a pneumonia with an associated pleural effusion. So this meniscus here. So this could be an empyema. So this patient here may need a pleural ultrasound, and if there's fluid, we might need to do a tap. And if it comes out as pus, we might need to put a chest drain in if that's safe. So look for the meniscus that suggests more than just a pneumonia going on. That could be an empyema, which might require chest drainage. So then onto treatment. So if a patient is hypoxic, they need oxygen. If they are hypotensive, or they're dehydrated, or they've got an AKI, or they're not passing much urine, they need fluids. And then we need to treat the underlying pneumonia with antibiotics. And the question there is always which and which route. So this is where this severity assessment for pneumonia comes in. So I expect you're all familiar with CURB 65. So in hospitals where we've got access to blood testing, we use CURB 65, and it's a 5-point scoring system that tells us how severe the pneumonia is, that predicts mortality, and that will also determine which antibiotic choice, so which antibiotic type and which antibiotic route that we should use. So you score 1 point for each of new confusion, a urea of greater than 7, a respiratory rate of greater than 30, a systolic blood pressure of less than 90 or diastolic of less than 60, age more than 65 years. So if you get 1 point for all of those, you've got a CURB 65 of 5. And if you get 0, if you get no points, you've got a CURB 65 of 0. And the lower the number, the lower your risk of death. And once you're on to 2 or more, your risk of death increases. And that also informs your antibiotic choice. So if you've got a CURB 65 score of 0 to 1, we call that mild community acquired pneumonia, and the mortality there is probably about 2 to 4%. And these patients can probably be treated safely as outpatients with oral antibiotics, unless they are hypoxic or have a comorbidity or another reason for being admitted to hospital. So I've been looking at this recently, trying to work out the criteria for Liverpool CRT's respiratory virtual ward for patients with pneumonia. So I'm thinking most of the patients with mild community-acquired pneumonia, 0 to 1, probably wouldn't qualify for pneumonia virtual ward, because they probably wouldn't be in hospital if we didn't have a virtual ward, unless they have a comorbidity or another reason. And it's probably safe, and this is Liverpool University Hospital Foundation Trust's antibiotic formulary. They suggest amoxicillin at a dose of 1 gram 3 times a day for 5 days. Frustratingly, this is different from our community dosage, which is still 500 milligrams 3 times a day for 5 days. But because we're employed by Luft, we follow the Luft guidelines. So it's amoxicillin 1 gram 3 times a day for 5 days. And that's a solo agent. You don't need to add in clarithromycin unless you think there might be Legionella or some other organism that might not respond to amoxicillin. Sorry, somebody's not muted. Jackie, I think you're not muted. Thank you. If a patient's penicillin allergic, then the alternative there is doxycycline. So they get 200 milligrams stat and then 100 milligrams twice a day. If you've got a CURB score of CAP, your mortality is between 9 and 14 or thereabouts %. So that's moderate CAP. So that the BTS says these patients could be treated at home or in the hospital, and they suggest if they're treated at home, maybe that should be under direct supervision of a hospital team. So I think they are perfect for pneumonia virtual wards. They could still be treated with oral antibiotics, but as well as the amoxicillin, they should have clarithromycin added in at a dose of 500 milligrams twice daily. And again, if they're penicillin allergic, they just get doxycycline at the same dose as the CAP, the CURB 0 to 1 as a single agent. Once your CURB 65 is 3 or more, your mortality is above 20% and maybe up to about 45%. So these are the patients that are very poorly with pneumonia, that certainly need to be admitted to hospital, that certainly need intravenous antibiotics at least to start off with. And if they're scoring 4 or 5, they should be considered for treatment on a high dependency area, so in critical care, because these patients are at risk of deteriorating and needing ventilation or vasopressor support. So those patients should definitely be admitted to hospital, and I wouldn't like to see any of those on my pneumonia virtual ward. And they need intravenous antibiotics until they get better. So intravenous amoxicillin with oral clarithromycin. If they're very unwell, they might need a stat dose of gentamicin. They might even need the gentamicin continuing. And if they're penicillin allergic, the recommendation is IV ticaplanin, oral clarithromycin, and maybe some gentamicin. In terms of pneumonia virtual ward, these patients will hopefully get better. And I suppose if you wanted to rescore their curb, once they got to 2 or less, we could consider discharging those as an early supported discharge on the pneumonia virtual ward. So I think that's probably the direction that we'll go in Liverpool. And I don't know how that mirrors what people that are already offering pneumonia in their respiratory virtual ward is doing. Right. In the community, traditionally, we've not checked bloods, although maybe we will as part of our respiratory virtual ward point of care testing. And I think if we are checking using these in the community, we should use curve 65 because it's a much more accurate severity assessment. However, if we don't have access to U&E point of care testing, then we should use this modified curve 65, which is a CRB 65, and that's just a 4-point score. So 0 will be mild, 1 will be moderate, 2, 3, and 4 will be severe. So mild might not need us. 1 could be treated in hospital or at home, perhaps on the virtual ward, and 2, 3, and 4 perhaps should be in hospital. And again, the same CRB parameters. Just a brief note about advancing quality and care bundles. So several years ago, the British Thoracic Society did a national project to look at if we apply care bundles to COPD and pneumonia patients, does this improve outcomes? And certainly it does in community-acquired pneumonia and COPD. So if we act quickly to make a diagnosis, prescribe oxygen, and give appropriate antibiotics within 4 hours, it saves lives and it reduces length of stay. So advancing quality was a big proponent of this, as was the British Thoracic Society. So the guidelines are that patients should get a chest X-ray within 4 hours of presentation. If they're in hospital, they should have an oxygen prescription, they should have a curb 65 score, and they should be given their first dose of antibiotics within 4 hours. So time is of the essence with pneumonia, as it is with sepsis. I think we're much better at treating sepsis promptly or potential sepsis promptly than pneumonia, but I think it's very important to treat these patients promptly. Which brings me into sepsis. So sepsis can occur as a result of as pneumonia, but infections in other places, in other organ systems in the body. So I'll talk about the definition, how we recognise it, how we treat it, and how it might be relevant to community services. So sepsis, by definition, is a life-threatening organ dysfunction due to dysregulated host response to infection. So it's not so much the direct effect of the organism that causes the sepsis, the hypotension. It's the body's response to it. So the body seems to go into overdrive and produce an exaggerated response to infection, and that's when people present with sepsis. It's essentially patients with an infection plus evidence of organ failure, or a higher risk of death or ITU admission, or seriously ill patients with an infection. But it's essentially the host response to infection. How do we recognise it? So there are some hard parameters for recognising it, but then we've got the soft signs as well. So you've all been working in nursing and medicine for years and years and years, and you've developed a kind of a spidey sense for how a patient is. And sometimes you might not be able to put your finger on exactly what isn't right, but you just think something's not quite right. And in sepsis, that is felt to be just as important as somebody's news score or somebody's temperature. So if you think somebody just doesn't look right, you've got a bad feeling about it, then don't ignore it. Act, get the patient admitted, get the patient checked out. Better to be safe than sorry. Anybody with a news of 5 or more could very well have a news of 5 or more because they have sepsis, so we'll be very worried about those. Again, risk factors like immunosuppression put you more at risk of developing sepsis. And then we talk about septic shock. So septic shock is sepsis with a low blood pressure, which is defined as a systolic blood pressure of less than 90, or a high lactate, which is a lactate of more than 4, despite adequate IV fluids. So somebody might come into hospital with a low blood pressure and high lactate. You give them IV fluids and their blood pressure comes up and their lactate comes down. That's fine. We're happy. If that doesn't happen after an hour or two, a couple of bags of fluid, then we'd be very, very worried that this patient might have septic shock. Patients with sepsis might feel very cold, might feel very hot, whether or not they have a temperature, and they might shiver. So that's a worrying sign. They might describe extreme pain or general discomfort, but they will describe it as the worst pain ever. They might just feel awful. Pale or discoloured skin is a real worrying sign. That might suggest tissue hypoperfusion because of low blood pressure. They might be sleepy, difficult to wake up or confused, and that implies that their brain oxygenation is failing because either they're hypoxic or their blood pressure is low enough that they're not perfusing their cerebral, that they're not perfusing their brains. If they say they feel that like they might die, that might be a pointer, and they might be short of breath. So the hypoxic can breathe fast, or just as part of the sepsis response, they become tachypneic. So in kind of more black and white terms, sepsis might come to light because the patient's got a news of 5 or more, if they've got tachypnea of greater than 30, if they're hypoxic, if they're tachycardic, if they're hypotensive, cyanosed, if they're not weeing, if they've got high lactate, if there's an AKI or evidence of organ dysfunction. So I suppose that's your drowsiness, and abnormal liver blood tests as well suggest that there might be organ dysfunction, poorly perfused liver. The Royal or Luft has a sepsis pathway, and that essentially encourages people to ponder whether there's a clinical suspicion of infection. Think about what the source may be, because that might guide your antibiotic choice. Look for 2 or more of a high respiratory rate, heart rate, high or low temperature, new confusion, high BM if the patient's not diabetic, or a low or a high white cell count. Ask if the patient is high risk. Do they look sick? Is their news 5 or more? Have they had chemo recently? And the higher your respiratory rate, the worse your sepsis is and the worse your prognosis is. So as soon as your respiratory rate is going above 25, your SAT's less than 92, your blood pressure low, your heart rate very high, confusion, not weeing much, AKI or evidence of other organ dysfunction, those patients are high risk and might need to go to ITU if that's appropriate. So we treat sepsis with the sepsis 6, and oxygen to maintain target saturation. Fluids are really important. These people are often hypoxic because they're vasodilated. So if you vasodilate and you've got a normal blood volume, you've got a lot more blood vessel volume to fill, so your blood pressure will drop and your tissue perfusion will drop. So we need to improve the amount of fluid in that enlarged space caused by vasodilatation. So we give lots of fluids. Check bloods, so full blood count for a white cell count, U and E for the urea and creatinine and GFR, LFTs to see if there's any end organ damage. CRP is a marker of infection. Clotting as well, so clotting can go off if you're septic. If you're septic, you can get DIC. Always send blood cultures and any other cultures that you think are relevant. So if somebody's got a pneumonia, send off sputum. If you think it's a UTI, send off urine. Give antibiotics within 1 hour. So for sepsis, it's really important to get antibiotics in very quickly. So for pneumonia, we're saying within 4 hours, but for sepsis, it should be within 1 hour. They need a fluid balance chart and think about critical care if they're not improving after fluid replacement, because they might need vasopressors to try and combat the vasodilatation that's causing the hypotension. So this is a sepsis 6, and this is in no particular order. It has been kind of made into an acronym Buffalo, which kind of takes in all these letters, but that doesn't quite spell buffalo, so it's not quite right. But high flow oxygen, that's your O. Take blood cultures, B. Give IV antibiotics, A. Start fluid resuscitation, F. Check lactate, L, and monitor urine output. So essentially, this is where buffalo comes from. So blood cultures, urine output and vital signs, fluid resuscitation, antibiotics, lactate and oxygen. So that's a buffalo, I suppose. I think they missed a trick. They could have said blood cultures, urine output, fluid resuscitation. Then they could have said more fluids, give another F, and then antibiotics, lactate and oxygen, and that would have been buffalo spelled correctly. But anyway, that's the acronym for kind of fast and appropriate management of sepsis. So in the community, we don't have access to a lot of the things in hospital, but we do recognise that any delay in diagnosis can be catastrophic because these patients are very sick and they need antibiotics very quickly. We won't individually see many cases in our lifetime, as opposed to if you work in A&E, you'll see them most days, I imagine. We often see patients early in the course of illness when it's not as obvious. And we've got no access to urgent investigation. So essentially, I think the take-home point for community practitioners is have a high index of suspicion and a low threshold for referring in for help. So use observations and early warning scores, which I think we all do. Use safety netting. So tell the patients if they feel worse, if anything changes. Call an ambulance, don't delay. Use a standard referral method from primary to secondary care. So I think if anybody kind of presses the sepsis button, NWAS will act very, very quickly, and the ED will be on standby to receive anybody with potential sepsis because they need to investigate and treat them very, very quickly. And clinical staff should all be trained about sepsis, and I think it's part of our mandatory training as well. There's a suggestion that there's a sepsis champion for each community team, so I don't know if you've got one or not, and if not, whether you want to think about identifying somebody who will just kind of wave the sepsis flag. It's not too difficult for some of our patients without sepsis to score 5 or more. So it's difficult sometimes, isn't it, to decide, is that 5 or more? Is that just kind of like just a slight deterioration in this patient's COPD or pneumonia, or are they septic? So I think if you're in any doubt, discuss with your senior clinical decision maker, or consider referring in to A&E for a patient to be reviewed, to exclude or rule in sepsis and discharge back or admit if they need more investigation and management. And this is Liverpool's urgent care pathway. So use your clinical judgment. If you suspect infection and you think that there's sepsis, then ring the GP ambulance hotline, say sepsis, and somebody will get to the patient very quickly and take them into hospital. So what's a reasonable response to triggers? News of more than 5, probably need to go to hospital unless you're absolutely sure that there's no sepsis there. Between 3 or 4 might need hospital assessment. I think it depends on what the patient's normal news is, how different it is to usual, what the individual changes in each of the parameters are, what the patient looks like. Is a patient drowsy? Is a patient hypoxic? Is a patient breathless? If you're not going to send them in, then certainly provide safety netting. And if you've seen patients that scoring high on news, but you're not sending them in, maybe a face-to-face review until you're happy that they've got better. You might even want to do another face-to-face review later on that day if you've got a bad feeling about patients. And then anybody with news or 2 or less, they're probably all right to stay at home unless there's something else that makes you worry about sepsis. And if we know a baseline news score, then any change from the baseline of 2 or 3 is a concern. And that is the end of the talk. So happy to take any questions you might have, if anybody's got any. Anybody want to ask any questions about CAP or sepsis or anything else I can help you with today?
Justine, shall I stop
Yes.
recording and then people might ask questions? Is that okay?
Yeah, happy, fine.
Yeah, I'll stop the recording and then everyone can feel free to ask questions.